back here.
Hello, everybody. Happy Tuesday. You're live with Dr. Terrellin. Thanks for joining us today. I'm Dr. Terrellin, your board certified family physician, speaker, author, and career coach. I help physicians navigate their next careers when they are burned out in order to help them find fulfillment in their careers. I'm happy to be here with Dr. Gina Williams. Yay! She is here today to help us learn just what a medical director does. And you know that the purpose of, or at least my purpose and my passion, is to help those who are considering a career change, whether it's in or out of medicine, just know what the possibilities are. There are lots of possibilities, no matter what you're interested in medicine. And I don't want you to feel like you're pigeonholed. I don't want you to feel like you're limited. There are brilliant doctors just like you doing wonderful things in and outside of medicine. And one of those doctors is Dr. Gina Williams. And just to tell you about Dr. Williams, Dr. Gina Moore Williams is a native of rural Shelby County. She wanted me to let you know that rural Shelby County, Tennessee, where she attended public schools and matriculated to Fisk University in Nashville, Tennessee. While she was at Fisk, she was accepted into a joint program with Meharry Medical College, where she received her BA and MD in 7 years. So she's smart, y'all. She knows what she's talking about. After graduating as the president of her medical school class in 2000, she trained at the University of Cincinnati, after which she became dual board certified in internal medicine and pediatrics. During her career, she has worked in community health centers in DC as an academic clinician and a director of an adult sickle cell care team at the University of Chicago, and as a primary care clinician and lead physician for Baptist Hospital, Christ Community Health Center's Operation Outreach, which provides medical care for the homeless. She has many accolades and done a lot of community work. But what we've brought you here for to hear about is she is a medical director for a large payer. And it's what we're interested in. And the other thing that's really important to her is that we want to highlight is Dr. Williams is married. She enjoys spending time with her husband, Jeffrey, who recently retired from 22 years of service as a U.S. Navy chief. And they have 3 children, Deja, Isaiah, and Dominic. Please help me welcome Dr. Williams. Yay!
Thank you for having me. I'm happy to be here.
Thank you, Dr. Williams. So let's just start with the obvious question. And I like to start with what led you to your career journey in medicine? And then how did you shift from being a board certified, not just board certified in one specialty, but 2 specialties, internal medicine and pediatrics, to a non-clinical physician executive / medical director? So take us through that journey.
Sure. So I always talk about wanting to be a doctor from the time I was like 5 years old. And so I heard that doctors heal people. And I thought, well, why wouldn't anybody and everybody want to do this job? And so I definitely thought of medicine as just growing up in a rural area, even though it's outside of Memphis. I definitely thought I'll become a doctor and I'll give people medical services in exchange for like jam and eggs that they collected. So I envisioned this whole practice that involved bartering, I guess, for medical care and getting the opportunity to speak to people about their like family members. So not only to say, hey, I saw your, congratulations, you just had a baby. How's your grandmother doing? Make sure, she follows up because she had a nasty, cut on her hand. And so that's what I originally envisioned. And as I went through college and med school and residency, obviously that vision changed, as it does for a lot of us, because the reality of medicine is not the dream of medicine, right? That we typically envision when you're children, right, or when you're a child. And so over the course of time, I became interested in doing primary care. That's always been at the heart of what I wanted to do. And I really wanted to always serve people who were essentially forgotten. And a lot of that is just based on personal experiences and, having family members who were rural and didn't have access to great healthcare, and even having family members who were located in urban areas and just didn't have great access to healthcare. And so I really have always had a heart for taking care of people who don't always get the attention, who are marginalized, and for taking care of people across the age spectrum. And that's what led me to doing a combined residency in internal medicine and pediatrics. So I really wanted to be an expert per se in all the ages, and I really enjoyed training in med peds and then going into community health. So as you know from experience together, we worked together in community health some at the beginning of my career in clinical medicine. And for years, I really got a chance to enjoy doing clinical medicine really on the East Coast, so in the DC area, in the DMV, as well as in the South here in Memphis, and then in the Midwest in Chicago. So I spent, about 12 plus years in clinical care after completing residency, and enjoyed that a great deal. And then I got the chance to go into academic medicine and to work at University of Chicago, which I really enjoyed because the teaching experience I think is almost second to none. And then I also got to advocate for a group of people who are, again, often marginalized, so people living with sickle cell disease. And it was at that point that I learned about the business side of medicine, because everyone knows that it's sickle cell is a complex disease process, and it requires really advocating for your patients and making sure you understand everything, and that everything for hospitals and for facilities is the bottom line. And how do we pay for this care with a complex population? And so that's where I kind of got interested in the business side. And that's when I first learned that there were people who had gone to medical school, had practiced in many incidents, and they were the ones that I would speak to for peer-to-peer calls, and to find out, okay, wait, so we have a limit as to what we can do because there are policies in place for this. And that really opened up my eyes to the beyond the bedside part of medicine. And it was helpful to be on a lot of committees, because you're on a lot of committees with pharmacy utilization and with a lot of areas of medicine that we just don't think about from day to day when you're seeing patients, from sun up to sundown. So that's what first piqued my interest in managed care and the business part of medicine. And then several years ago, I was able to, I started kind of looking around to see what was out there in terms of opportunities. And I was looking for a clinical change. And so one of the things I always talk about is I enjoyed seeing patients and I enjoyed clinical medicine. But I also was experiencing a more personal side of medicine, because at that time that I made the transition from clinical care to managed care, my father was ill. And so I went through a journey with him with terminal cancer, and really just kind of got a little bit heartbroken with that whole experience on a personal level. And I really didn't feel like the compassion and the drive and the interest in everyday clinical care was there as much anymore. I kind of lost a little bit of that, and I felt like if I couldn't maintain the compassion that I had for clinical care or the heart for it each and every day, it would be doing a disservice to patients. And I started looking for opportunities to transition to managed care. And then that opportunity came. Oh, go ahead.
I just want to jump in there because I think you bring up a really important point that a lot of us don't think about, especially when we're going through medical school, when we're training. Because if you think about it, a lot of us come through college, we come through residency, but we don't think about it, about the responsibilities that come as we age, when we have aging parents, when we have to take care of children, and then life happens.
Yes.
And of course, we don't plan for these things. And then there's that major event that makes us stop and think, okay, what do I do here? And a lot of times our career, the career path that we set up on, doesn't really, may not necessarily agree with the choice that we need to make. And so I really honor, really honor the choice that you made with saying, hey, my father, I need to take care of my father right now. I need to make a choice right now that may not be, I may need to step out of clinical medicine. And I think right now you're giving some other physician right now to say, okay, this is okay to not to step away from clinical medicine. And I think a lot of us weren't given permission, or we aren't giving ourselves permission to do that. So go ahead.
Yeah, I just more on that point that you just made is I think we are taught to always be achieving, right? So you have to knock down this other thing, you have to knock down this barrier, you have to go through this glass ceiling, and we're so focused on achieving just to become physicians in the first place that we lose sight of making sure that we are appreciating work-life balance. And sometimes the life part or your home balance takes more of a priority than the work balance. And I think because the culture of medicine traditionally has been, no, you have to do this and you have to achieve this, and then you have to keep climbing the ladder until you get to the very top, until you're like Surgeon General. And I think we don't stop to imagine and to appreciate that life happens along the way. And so that's very much the transition that I had in that time period. And it made me step back and just reassess what was meaningful to me and what was meaningful to patients. Because I think whatever spirit you go into medicine, whatever drives you to go into medicine, if you want to heal, if you want to take care of people who normally don't have the same resources as you may have, then you want to make sure that you're staying true to that. And I feel like that was the assessment that I had to kind of make at that time. And so about seven and a half, it'll be 8 years, I guess, 8 years ago, I transitioned. There was an opportunity to work for a large payer and to work as a Medicaid managed care associate medical director. So someone who reports up to a chief medical officer. And I jumped at the chance and did that. And since then, I've kind of done a little bit of work in different areas of managed care. So some commercial work, some work in appeals, but essentially now I found myself back in that same position again 7 years later. And so I have enjoyed the transition because the population that we serve is a Medicaid population. It's still staying true to, my heart for people who are under and uninsured, but underinsured typically. And so I've enjoyed being able to have a different kind of impact compared to, seeing patients in and out from day to day.
So I think we should make a distinction here, and thank you for letting us know. We should make a distinction that all medical director positions are not created equal, right?
Yes, absolutely.
So you have just highlighted that you are a medical director at a payer/insurance plan or company, but you are mainly doing it for a Medicaid population.
Absolutely.
So tell us or take us through what might be a typical day, if there is such a typical day,
Sure.
or what your main responsibilities are as a medical director who takes care of a Medicaid population.
Okay. Thank you for talking about that distinction, because I think when people think of medical directors in managed care, they often think of the people who are denying all of my procedures, right? And they're denying
right.
That's exactly what they think about.
Right.
That's maybe 15 to 20% of what I do from day to day. But with Medicaid managed care, specifically in the role that I'm in now, our focus is not only our members who have our Medicaid, but it also the state partners. So basically, who has oversight over how we spend state funding for Medicaid patients, right? And so a typical day is, I'll walk you through what tomorrow will be. So typically I will start and look at the schedule and make sure I'm responding to emails. The emails could be about, there's never a boring day. So I could come up with 20 different things that I do in the course of a day. But sometimes it's, we have somebody who has some behavioral health issues, and they also have several chronic medical diseases as well. And they've been hospitalized multiple times. And we need to try to connect them to resources with a case manager to try to keep them from being readmitted to the hospital repeatedly. So that's what drives a lot of the conversations and meetings that I have from day to day. But so a typical day, or like tomorrow, would be that I would come in and check emails, respond to different requests, which I'll get to in a second, and then we'll have rounds. We'll have clinical rounds on private duty nursing. And those rounds entail nurses or case managers who have gone in, done assessments, and said, you know what, this person has cerebral palsy. They also have schizophrenia. They also have these wounds, and they have diabetes, and they have multiple issues. And they need so many hours of support from an outside entity. So they need so many skilled nursing hours. Do you approve this, or do you think there's an alternative? And so typically it's going through to see if something is medically necessary, right? So like, you've done an assessment, we have objective tools to determine, okay, they need 40 hours a week of this care so that we can hopefully keep them at home and healthy and out of the hospital, right? So we'll typically have rounds for 30 to 60 minutes, and we'll talk through a lot of our members, because, you know, on the insurance side, they're called members and not patients, because we're not treating or diagnosing them. So we'll have rounds, and then we may have a meeting about affordability initiatives. So we found, okay, there's a respiratory care provider that will go in and make assessments with their respiratory therapist, with a nurse on our team, and they'll determine, okay, this person could probably wean off of a ventilator, a chronic ventilator, and probably wean off of that. How do we best accomplish this, and what are all of their needs? So what are their durable medical equipment needs? What are their skilled nursing needs? Do they have family support? If not, how much support will we need to do to complement that family support? So that's typically something. The utilization management part is, unfortunately, there are times when someone on a larger team, on a larger national team, will say, I reviewed this case, this person did not need to be in the hospital for 6 days. And because they were in the hospital beyond the 2 days that they really could have been observed, they got a UTI, and then, or they had a hospital-acquired infection, which prolonged their stay. And this is really on the fault of the facility and not providing care that was, medically necessary. So there is a small portion where those complaints will go through the process. So we'll typically have someone review it at the time the person's in the hospital and even after they've been discharged. And then those complaints or those issues will then go to the state, and the state will then send them to us. And I'm the person who reviews those cases and says, okay, well, based on these guidelines, though, I think that I kind of have a differing opinion from the previous or the former person who reviewed this. And I think that they meet criteria for medical necessity, and I would overturn and then say we should approve payment. So that happens.
So that's great, Dr. Williams, because I want to highlight that, especially for the physicians out there, just so they know that there is a human, there is a doctor out there who still can advocate for them. So just in the example that you gave, they have asked for a particular treatment for the patient. It goes to a team or that has reviewed it and against a policy. And they have determined that just based on the documentation and that policy that that they will not cover it or it should not cover it. But if the physician feels very strongly, then they might escalate it to someone like you. And then you have the power to say, okay, I've reviewed this information and I do deem it necessary. And so I think that's really important because it says that, hey, there is a human, there is a doctor who is using her expertise, who is not just looking at paperwork, who's not just using a policy, but is using her expertise, who is using empathy and compassion, and is remembering that there is a person, there is a body in the bed, and saying, okay, this is necessary work. Because I think we're highlighting that this job is just not, you're just not pushing papers. You really are taking it into account. It really is, you are caring in a different way. You may not be seeing the patient with your own eyes, but you are taking care of that patient or advocating as much as you can.
Right. And another part of my job that's related to that is being a liaison between medical providers and our managed care company or our managed care organization. So one of the things that I really enjoy doing is trying to provide that perspective and trying to recruit people within the medical community in my area to say, could you join our meetings so that we can make sure we're getting input from you all so you can see what we do, and to kind of provide transparency on things like policy changes, on audits that we conduct, just to give context for what we do all day and to hopefully provide that connection. And so provider affairs is an important part of that job, and reaching out to people to say, no, just come to this meeting so you can see that these changes have just happened. Now we realize that this standard of care procedure for otolaryngology this is now standard of care. So we have now made changes with this policy, and you should be aware of that. And then if you have issues just with approving something that you know is medically necessary for your patient, then it provides a connection to someone who can, on a more local level, say, okay, this makes sense. They sent supporting information that doesn't fit our criteria, right? But the supporting documentation that they have sent, because we have that relationship, really does benefit their patients and our members. And so that's a big part of the role, as well as quality of care. And that's another area that I just want to touch on. So when a member of ours has a concern or has had a procedure or they've had a complication from something, they can file a complaint. And it's basically reviewed, and we then make recommendations on whether or not there was standard of care followed, or if there was a deviation from standard of care. And if there was a significant deviation from standard of care, let's say you got someone who's running a pill mill. Unfortunately, that's just the reality of today. And so if you've got someone operating a pill mill and you know that this ruins the integrity for the medical community as a whole, then we get to investigate those things and say, I don't know if that's somebody we want in our network. So I think it's definitely an interesting role, and I just never have a bored moment. There's never a boring moment. So that's what I enjoy about this role.
Well, Dr. Williams, you've definitely shed a positive light on a position where I think has been nebulous at best for some people.
Right.
Is any last words or anything you want to share as we wrap up this interview? And I just want to say thank you, because you really have just given a great explanation on something I know I get a lot of questions about, as far as what does a medical director do?
Right.
And even though yours, I know I hear, once you've seen one medical director, you've seen one medical director.
Right.
But thank you for that.
And they're very, yes. So I think it's just on a broader level, because you talk about different opportunities in medicine and even transitioning from clinical care. What I think is what's been maintained is the interest in medicine as a whole, and your ability to recreate yourself every few years. I think that's invaluable. And I think that we have so many tools in that one degree that people don't always take of it. So I might transition back into clinical care. I might do more telehealth, or I might do more work that's not clinical, or I may do more clinical work. And I think that's the number one thing I would want to get across, is just be open to opportunities. And if you want to transition and become a totally different person, I've experienced that. And I love that medicine has always allowed me to do that, to change from primary care to focusing on sickle cell and to running a program and to going to managed care and having different roles within managed care. And I think that's the tool. The key tool in that is our degree, right? And then your training, and you can just reinvent yourself. I think I've never been afraid to change. As you know, over the course of the time that we've known each other, I've had like 10 different roles, but
hey, it's called versatility.
No, exactly. So I think just always recognizing that the power in the tool of the medical degree is important. And I'm glad that you highlight those different opportunities.
Well, thank you. And it's so good to know amazing colleagues like yourself who are helping us out and advocating, especially on the business side of medicine, and advocating for our patients. And with that, we'll wrap up. If folks have questions, are you open to having them contact you?
Oh yeah, absolutely.
Okay. Is it okay if they just hit you up on social media?
Yeah, that's fine.
Direct. So how can they?
Oh yes. How about I give that information? You can either I'm on Facebook. Oh, goodness, let me see. I don't even know my handles anymore. So I'm on LinkedIn as Gina. I'm sure I'm Gina Williams, or Gina M. Williams on LinkedIn, or Gina Williams on LinkedIn. I'm on Facebook as GM Will. I'm on Instagram as GMODub, GMODUB. And then I don't know if you have an email, or if I can even put it. I don't know.
But I can type it in and it can show up.
Yeah, that would be great.
But all right, give it to me.
Yes, absolutely.
Give it to me.
Or I don't know. Can I type it in here? I can do that.
Okay.
Here, I'll type
it in the chat.
Okay. Got it?
And let's see if I can show it. I think it says private chat, so I don't know if it'll be able to show.
Oh, you know what? Cute. Put it on the right. Let's see.
It's Gmore Williams at Outlook. Okay, so then I'll put it. Let's see if I can do that.
And then I put that other. Okay, I'm going to stop sending you candles for a second.
Let's see. All right, how about I put that there?
Awesome.
For folks. And we'll leave it there.
Okay.
All right, thank you so much. And folks, if you have any more questions, Dr. Williams' email is there, and you can also hit her up on her socials. I am Dr. Terrell, and your board certified family physician, speaker, and physician career coach. If you would like to contact me, feel free to hit me up at Dr. Terrellin on all socials. If you'd like to invite me to speak, same thing, hit me up on all your socials. And thank you. You can join me back next week, Tuesday, 7 p.m. Eastern. And I'll see you next time. Thank you, Dr. Williams. Thank you, everybody.
Thank you, Dr. Carolyn.